The test item cluster for mechanical neck pain likely to benefit from thoracic manipulation includes symptoms less than 30 days, no symptoms distal to the shoulder, looking up does not aggravate symptoms, an FABQ score for physical activity less than 12, diminished upper thoracic spine kyphosis, and cervical extension range of motion less than 30 degrees. All right, Katie, go ahead and look up to the ceiling for me, please. Good. The test item cluster for full thickness rotator cuff tear includes the drop arm sign, where the patient's arm is abducted to 90 degrees and the examiner asks them to slowly lower their arm to their side. Good. The painful arc sign, where the patient is instructed to move through their full range of motion, as I do. Go ahead and abduct your arm. Good. And the examiner notes any pain within that range. The infraspinatus muscle test, where the patient's elbow is flexed to 90 degrees and they're medially rotated to 45 degrees. The examiner applies a medially rotated force that the patient resists. Good. The test item cluster for subacromial impingement includes the painful arc sign and the infraspinatus muscle test, which were both previously demonstrated, as well as the Hawkins-Kennedy test, where the arm is forward flexed to 90 degrees and the examiner applies a downward force and notes any pain with that motion. The test item cluster for patients with mechanical neck pain likely to benefit from cervical manipulation includes symptoms less than 38 days, expectation that manipulation will help, and a cervical rotation range of motion difference of 10 degrees or more between sides. Go ahead and rotate to your right. Good, and your left. Good. It also includes pain with a posterior to anterior testing of the mid-cervical spine. The patient is prone with a pillow under their chest if their head and neck are in neutral. The examiner places their thumbs over the spinous process of the targeted vertebrae and applies a gentle posterior to anterior force to assess mobility, infeel, and pain. The test item cluster for cervical radiculopathy includes less than 60 degrees ipsilateral cervical rotation, a positive Sperling's test, where the patient side bends their head to the symptomatic side, go ahead, and the examiner applies overpressure. Okay. A positive distraction test, where the examiner cradles the head and then applies a distraction force. And lastly, an upper limb tension test for the median nerve, where the patient's arm is abducted to 90 degrees and their scapula is depressed, their forearm is supinated, their wrist and fingers are then extended, and then the elbow is slowly extended. The upper limb tension test for the radial nerve. The patient's arm is abducted to 10 degrees and the examiner depresses the scapula with their thigh. The patient's forearm is then pronated and the shoulder is medially rotated. The wrist and fingers are flexed and the elbow is flexed to 90 degrees. The examiner then extends the elbow slowly. The patient is asked to report any symptoms. You can sensitize this test by having the patient do lateral flexion of their cervical spine, contralaterally or ipsilaterally. For the differential diagnosis between a rotator cuff tear and a C5-C6 radiculopathy, a rotator cuff tear would present with limited and weak shoulder active range of motion, but full passive range of motion, a positive drop arm sign, a positive infraspinatus muscle test, a positive Hawkins-Kennedy impingement test, a negative distraction test, a negative upper limb tension test, a negative Sperling's test, and normal reflexes and sensation. All those tests were previously demonstrated. A C5-C6 radiculopathy would present with limited cervical ipsilateral rotation, as well as a positive distraction test, a positive upper limb tension test, a positive Sperling test, and a positive shoulder abduction test. Go ahead and raise your arm and put your hand on your head. Good. And I would then ask the patient if that changed their symptoms in any way. A C5-C6 radiculopathy would also present with a negative Hawkins-Kennedy test. Weakness in the C5-C6 myotomes, specifically shoulder abduction, elbow flexion, and wrist extension. Numbness and tingling in the C5-C6 dermatomal distribution, and a decreased biceps and brachioradialis. The load and shift test. The load portion is done by lifting the humerus and positioning it in the glenoid fossa. The shift portion is then done by translating it anteriorly or posteriorly, and the examiner notes the amount of translation in the end feel. You must compare bilaterally to determine atraumatic instability. The active compression test of O'Brien is used to detect superior labral tears. The arm is forward flexed to 90 degrees, adducted to about 10 to 20 degrees, and medially rotated. The examiner applies a downward force that the patient resists. The arm is then supinated, and the examiner applies that same downward force while the patient resists. The lift-off sign tests the strength of the subscapularis muscle. The patient places the back of their hand on their pocket. They then lift it off, and if they're able to do so, the examiner applies a force that the patient resists. The supraspinatus or MD-CAN test is used to assess supraspinatus tendon pathology. The patient's arm is abducted to 90 degrees with the hand in neutral, and the examiner applies a downward force. The hand is then placed in scaption and medially rotated so that the thumb is pointing down in the MD-CAN position. A downward force is applied again.